All right, good evening, everyone. Welcome to tonight's CE at Home for the members-only webinar. I'm Dr. Jeff Spears, a member of the OAO Continuing Education Committee. Just a few quick housekeeping remarks before we do get underway. In order to verify your full attendance for tonight's session, the time that you log in and out will be used to track your continuing education credit. This will be a 1-hour Category B credit. A speaker and course evaluation will automatically be emailed to you at the end of the session. We would appreciate sharing your thoughts on the quality of tonight's presentation with the sponsor and our team. Your CE certificate, which will be emailed to the account you provided when you registered for this session, will be emailed to you shortly after the webinar. The OAO will be submitting your CE credits on behalf to ARBO using the OE tracker number that you were asked to supply. If you have not provided this OE tracker number as of yet, please contact Wanda at the OAO. We have over 200 attendees this evening, so in order to for everyone to enjoy this session, we have muted you all to avoid the background noise. If you would like to ask a question, please type it into the box in the bottom right-hand side. Dr. Sherman will select questions based on the time availability and at the end of the webinar. Please note, we may not get to all the questions, but we will log all questions and have answers posted in the next coming weeks on the OAO member website, along with recording of this webinar and the PowerPoint slides. If you would like a personal response from Optos, please also provide your email address so the company can follow up with you directly. Tonight's webinar is courtesy of an unrestricted education grant by Optos, a leading provider in retinal imaging devices to eye care professionals to enable improved patient care. Their core devices produce ultra-wide-field, high-resolution digital images of approximately 82% or 200 degrees of the retina, something no other device is capable of doing in a single image. The OptoMap image provides a bigger picture and more clinical information, which facilitates the early detection, management, and effective treatment of disorders and diseases evidenced within the retina. Optos has a range of retinal imaging devices that support different customer segments and patient needs, such as wellness screening carried out by optometrists in the primary care setting, or more exact imaging in the secondary care practices that are clinically managing a patient base with advanced ocular disease. Their most advanced imaging devices for disease management and treatment support ophthalmologists and retina specialists in the medical care market. Furthermore, the company continues to strengthen its clinical evidence and expand its disease indications to demonstrate the importance of imaging the entire retina. Your speaker tonight is Dr. Jerome Sherman. Dr. Sherman is a graduate of the Pennsylvania College of Optometry and currently holds a position of the Distinguished Teacher Professor at the State University of New York and Schumacher Institute of Vision Research. He continues to practice in the private care sector at the Eye Institute and Laser Center in New York City and is actively researching in the area of clinical ocular disease and special testing, which involves using the latest high-tech advanced diagnostic techniques and instruments. His publications include over 750 clinical articles, research manuscripts, book chapters, 2 CDs, and 4 books. Welcome, Dr. Sherman. Before I turn over the webinar to Dr. Sherman, we'd like to take a poll of the audience on whether they use autofluorescence in their office. We have 25% that use the autofluorescence and 75% do not currently use it. So I think this is a great webinar for this evening. Dr. Sherman, I'll hand it over to you.
Welcome, everyone. I know it's very, very late. We'll try to do this within an hour. And again, we do have some time for questions at the end. The topic is obvious. It's been introduced before. The importance of autofluorescence in retinal pathology diagnosis. And as for disclosures, I pretty much lecture for all the different companies within the ophthalmic world. And of course, Optos is one of them, but there are lots of others as well. Our agenda tonight is an overview of fundus autofluorescence, which we'll call either FAF or AF, interpreting these AF images. We'll do that. Examples of hyper and hypo-autofluorescence. We'll do some case studies, and we'll have a question and answer session at the end. The case studies. We're going to cover 15 cases. I really prefer to cover 50, but that would probably take about 3 hours, and we only have an hour, so we will get to these 15, as we'll see in a couple of moments. An overview. We think that autofluorescence is very, very useful in diagnosis and then for timely therapeutic intervention in a whole series of disorders. And that includes AMD, plaque retinal toxicity, inherited retinal disorders, optic nerve drusen, and the list goes down to multifocal central serous retinopathy. We're going to see a case of that. Some tumors, we'll see one of those, and some inflammatory diseases as well. So it really has a lot of advantages in many, many different types of cases, as I think we'll try to touch on. autofluorescent imaging in general. It's not invasive. We're not injecting anything. It's totally different than fluorescent angiography. In fluorescent angiography, the vessels look white. Here, the vessels look dark. Here, we're actually getting information about the retinal pigment epithelium, specifically a major pigment in the RP called lipofuscin, which is an aging pigment in the RP, which is actually produced by the outer segments of the photoreceptors. And this technology provides information which certainly goes over and above conventional imaging techniques in a lot of cases, not in all cases. It does allow us to visualize the metabolic changes at the level of the retinal pigment epithelium. And when the RPE becomes abnormal, so do the photoreceptors. And when the photoreceptors become abnormal, of course, that leads to a visual acuity loss, a visual field loss. And both of those are certainly possible. And we'll see examples of them. Interpreting AF images, well, as you can see, most of this image is sort of this granular gray glow. I think you can see my pointer over here. Occasionally, and notice, by the way, that the disc is relatively dark and the vessels are dark. That's because the disc and vessels typically don't have lipofuscin in them. The lipofuscin is actually giving the retinal pigment epithelium this sort of granular gray glow that we're seeing. We can get lighter areas, which are hyper-autofluorescent, and this identifies sick cells that result in this brighter white signal, as I think you can see. Generally, we're talking about sick cells or retinal pigment epithelial cells that are metabolically too active, more active than they should be, and that tells us that something's happening, sort of an active condition. Hypo, H-Y-P-O, hypoautofluorescence, shown here in the dark zone, is really telling us about dead retinal pigment epithelial cells. And if you have dead cells, you're going to have photoreceptors along with them that have also died, or at least are not functioning. So that's pretty much the very basic explanation of what we do. As you'll see, that often ultra-wide field autofluorescence reveals abnormalities which cannot be viewed with other imaging modalities. We're not going to compare this to a lot of other imaging modalities, but certainly we'll be comparing it to color images, as we'll see. So just begin with two examples. On the left is a zone of hyperautofluorescence, again, sick cells or cells that are metabolically active within the retinal pigment epithelium, with corresponding or early defects within the photoreceptors. On your right are hypo zones. This patient has chirpy congenital hypertrophy of the retinal pigment epithelium, and that is something that in about the 200 cases that have been reported is essentially always hypoautofluorescent. So those are the two extremes, if you will. Let's talk about something simple, a choroidal nevus that we all have experience with. They're found in about 10 or 11% of all ultra-wide field patients, or patients that have been imaged with ultra-wide field devices. Typically, choroidal nevus is at the level of a choroid, of course. And here we're looking at a composite ultra-wide field image. And composite meaning we're using red and green lasers together. You push the button once, you get a composite view, but you can always go back and separate it into the green laser separation and into red laser separation. Below on the right, you can see choroidal vessels, because the red actually penetrates below the retinal pigment epithelium and allows us to see down to the choroid. Now this lesion, which we've already defined as a choroidal nevus, is obviously at the level of the choroid, so it's visible. On our left over here, the green separation doesn't really show us the choroidal vessels, doesn't show us abnormalities within the choroid, but it does show us the retinal abnormalities if they were present, and the retinal vessels quite well. So here, with green laser separation, we're really seeing entities which are anterior to or in front of the retinal pigment epithelium. With the red laser separation on your right, we're actually going below the retinal pigment epithelium down to the choroid, and possibly even below that in certain cases. So here's the same patient with autofluorescence. Remember, this is autofluorescence and not fluorescent angiography. The disc is dark and the vessels are dark. And we're getting this sort of glow for most of the retinal pigment epithelium. The fovea can be a little bit darker than the rest of the fundus, and that would be normal. So here we're comparing the composite on the left, color composite, with the autofluorescence image. And you can see that the autofluorescence, as we defined before, is coming from the retinal pigment epithelium. So this lesion, which is invisible on autofluorescence, is below the retinal pigment epithelium. So this is typical for nevus. The only exception to this would be a nevus that has some drusen on the surface, and the drusen on the surface would show up as hyper or hypo, little tiny spots on top of it. But this one doesn't have any drusen on the surface, so it's really completely invisible to autofluorescence. That's what we expect. In contrast, let's talk about a patient with an amelanotic choroidal mass, meaning a choroidal mass that seems not to have any pigment. And there are such entities as amelanotic malignant melanomas. Okay, here's the patient. The color is on the upper left and the autofluorescence is on the lower right. Notice that it's obvious on the color, and it's also very, very obvious as a hyper-autofluorescent lesion on autofluorescence. This LASC is an amelanotic choroidal mass. It could be something like an amelanotic malignant melanoma, as we mentioned, or it could be a nevus, which is amelanotic. That's certainly possible too, but fairly rare. More likely, it's probably an inflammatory granuloma due to, say, sarcoid or syphilis or tuberculosis. Of interest, if these patients, by the way, should be evaluated, I should try to get an OCT through them if you can. Fluorescent angiography would be useful as well. But in some cases, we don't really find any systemic disorders, any inflammatory disorders systemically. And there is a name for this. We sometimes call this a solitary idiopathic choroiditis, which is a term which has actually, I think, been coined by Carol and her husband, Jerry Shields. So this is the kind of lesion that you'd be concerned about, because this could be an amelanotic malignant melanoma. It could be an inflammatory lesion telling us that there's something going on not only in the eye, but in the rest of the body. So this one, unlike the last one, the nevus, this one deserves a work. Here's the right eye of the same patient. This is the composite scan, as you can see. Here's the left with the composite, but here, of course, we have this lesion, which is temporal to the foci. And here we can look at it on autofluorescence. And obviously, we don't have a slide of comparing it directly, but we can go back and forth and see that it does show up on color and it does show up on autofluorescence. But a hyperautofluorescent lesion like this really deserves a full evaluation to be certain it's not in the kinds of conditions that we spoke about previously. Okay, let's go to a chirpy lesion, congenital hypertrophy of the retinal pigment epithelium. These are not that rare. We see them probably in about 1 in 10 patients if you do ultra-wide field imaging. So about 1 in 10 patients with ultra-wide field imaging have a nevi or nevus, or perhaps more than one, and then also about 1 in 10, 9 to 11% or so, have chirpy lesions. So combining these two dark lesions, about 1 in 5 patients actually has such a lesion. If we look at autofluorescence, these show up as being dark. Or practically black, as we can see here. This is actually related to the fact that the retinal pigment epithelium is actually hypertrophic. However, below it, the photoreceptors are missing. We know that when we do OCTs through these lesions. And without photoreceptors, we're not going to get the production of lipofuscin. So the lipofuscin, it's not that the RP is abnormal in this case. It's actually that the lipofuscin is not being produced. So in any instance, these chirpy lesions are typically always dark, as we're seeing here. So that's something to keep in mind. Here's a chirpy lesion from a student of mine, actually a resident. She came up to me the last day of her residency program and said, Dr. Sherman, take a peek at this lesion. In school, nobody knew what it was, and I wanted to dilate her, and she said, no, I refuse to be dilated. We were able to get Optos images without any difficulty, and then Optos autofluorescent images as well. So this is really a chirpy lesion, and we're not going to show it here, but we have OCTs through this lesion as well. So this is fairly typical for a chirpy lesion. Nothing to be too concerned about. It does show up as a dark spot on autofluorescence. Okay, let's go to a whole different series of disorders. Let's talk about some of the inherited diseases. We'll start with Stargardt's mac degen, which is the most common of the juvenile macular degenerations. Here's a patient who was referred to me by my brother, interestingly enough, seen by lots of different doctors, and mom says 15 over a period of 2 to 3 years, and they all said that everything was normal, the optic nerve was normal, the retina was normal, no cataracts or anything like that, and the loss of vision, which started at 20/30 and went down to 2200, was actually due to hysteria or malingering for some reason. In any instance, the fundus did look pretty normal. However, with autofluorescence, it was clearly abnormal. And if we compare both together, the right and left eye, we see this very close symmetry of the right and left eye. And this is typical for inherited disorders. Notice that the macula is oval, or at least the lesion is oval, and it's darker than it should be, which means, by definition, hypoautofluorescence. And as I mentioned previously, with hypoautofluorescent images, the photoreceptors are going to be involved. When we do OCT on this patient, the photoreceptors are actually missing. we can see this large zone of hyper-autofluorescence, as you can see, which is abnormal, which means the retinal pigment epithelium is being stressed. It's not dead as it is here in the macula area, but it's being stressed, it's sick, it's metabolically active. In addition, we have all these like flecks, and these flecks are very, very typical for Stargardt's disease. Again, the symmetry is fairly typical as what we'll see with all these inherited disorders. I shouldn't say all. Probably about 95 to 98% of inherited disorders are very, very symmetric. Maybe 1 to 3% are somewhat asymmetric. This is very typical of what we see in Stargardt's disease. Stargardt's is common from the point of view as being the most common of the inherited maculopathies, but it's still relatively rare, 1 in about 4,000 or 5,000 or so based upon who you're reading. Let's talk about a much more common disorder, which we'll call central serous chorioretinopathy. Here's a patient I presented with some vague blurred vision in the right eye. Not bad, actually. I think it was about 20/30. And you look at this ultra-wide field color image, and you don't really see a heck of a lot, except perhaps you say that, well, it looks like the patient has cupping, maybe physiological cupping, maybe it's actually pathological cupping associated with glaucoma. Let's look at the left eye. We also have cupping. But the retina itself really doesn't look remarkably abnormal. We're seeing all of these retinal vessels which show up really nicely. In addition, we're seeing choroidal vessels. So this patient could be lightly pigmented, or this patient could be a myope. So we're actually seeing with the color Daytona image, we're seeing retinal vessels and choroidal vessels at the same time. Not so unusual. You can compare the right and left. Maybe it's a little bit more vertical cupping on the left side. Patient does also, by the way, have glaucoma. But in addition to that, there's a retinal problem, which may not at all been obvious. So here we go. So what are we seeing on the right eye? Well, there's a zone here supratemporal to the disc, which is very, very dark. Again, that would be dead retinal pigment epithelial cells corresponding with dead or dysfunctional photoreceptors. Around it, you have some bright zones. Okay, so these are sick cells. Over here, we have what we sometimes call a descending tract, and this is due to fluid at some point leaking, and it goes inferiorly because of gravity. And that zone, as we'll see again, we saw it once, but we'll see it again in comparison, it's really pretty much invisible to ophthalmoscopy and to standard color imaging. It's also a zone of abnormality below the disc, and there's something in between. As you can see, it looks like the macula is not quite perfect. Acuity is only down a little bit because the macula is only minimally involved. Here's the left eye of the same patient. Patient has no symptoms in this eye, but there are 3 zones that are shown to be abnormal, as we can see here. Okay, let's do a comparison at some point. Here's a comparison of the right and left, but then we want to go back and actually look at the comparison between the color and the autofluorescence images. So here we are. We have the right eye shown on the left in color and on the right in autofluorescence. Notice the zones that are definitely abnormal in autofluorescence that really look pretty normal with the color imaging and with ophthalmoscopy. So let's actually compare them. We'll take a look at 4 of these zones. The first one over here, color, this actually looks pretty normal. When we look at the autofluorescence, clearly hypoautofluorescent with some spots around it. So this is a zone where the retinal pigment epithelium is dead, and so are the photoreceptors. This zone over here, perhaps we can see some subtle abnormality, but nothing remarkable. That's clearly abnormal with the autofluorescence. The zone down here with this oval looks really normal with ophthalmoscopy and looks normal with color imaging, but with autofluorescence, it's clearly abnormal. It's clearly hyperautofluorescent, meaning that the cells are not dead yet, but they're sick and they're stressed. Below the disc is another lesion which does not show up at all with color, but shows up on autofluorescence. Let's take a look at the left eye. Here are the 3 lesions in the left eye in autofluorescence. Let's just show them to you together here, and notice that they're really very, very difficult to see, if not impossible to see, with standard color imaging, but they're clearly there with autofluorescence. We also have fluorescein angiography on this patient and OCTs, just confirming the diagnosis, but we don't really have time to go into that. But central serous is certainly not a rare disorder, and it's really not central. For example, in this left eye, we can see there's nothing going on in the macula. And in the right eye, there's a subtle abnormality in the macula and a lot of lesions which are outside the macula. So it may be misnamed, and sometimes you find these changes really extensive in the retina. And it's an important condition to know about for differential diagnosis. Some treatment options are available for these patients, but usually it's sort of judicious neglect and we do nothing. We just follow the patient, and the patients get better by themselves in most cases. Let's talk about wet AMD. About 10% of patients with age-related mac to gen wind up going from dry to wet AMD. And here's such a patient. This is an 89-year-old. We can see on this color image, this is actually just a PVD. We can see some peripheral pigmentary changes, peripheral drusen, nasal, and temporal. But the macula itself looks okay in this right eye. And this 89-year-old female has 20/20 visual acuity. Here's what the autofluorescence looks like. Again, not much going on in the macula. You can see some of these peripheral changes, probably better seen nasally as dark spots. But then if we look at the left eye, the patient actually did have a membrane, a choroidal neovascularization membrane, meaning wet macular degeneration, was picked up in a timely fashion when the acuities was still good, and a friend of mine, a retinal specialist, actually lasered it. So this is just prior to anti-VEGF injections being available, and he was able to laser this lesion, which was below the fovea, sort of between the disc and the fovea and a little bit inferior. But the fovea itself is actually uninvolved. The patient still has 20/25 visual acuity. With standard color, it looks like it's white. So we're actually looking down probably at the sclera. Most of the retina is gone, most of the retinal pigment epithelium is gone, and we're looking deeper into the some of the choroid and actually down to the sclera. Here's what it looks like in autofluorescence. So it's completely black, or almost completely black. Again, the fovea is uninvolved, spared. The retinologist did a really good job with his laser. He was able to miss the fovea. And in this instance, we're looking at this hypoautofluorescent zone, which is telling us that the retinal pigment epithelium is dead. It's gone. It's missing. Okay, comparison of the two eyes. Sometimes drusen, as we saw in this right eye, can occur in mid and far periphery with not much going on centrally. But of course, in the same patient, in this case in the other eye, we can see that indeed this is the peripheral drusen, drusen here, which is sort of temporal to the fovea. These are somehow related to the lesion, which became from dry mac to gen to wet mac to gen. It's sort of interesting to see this kind of a pattern. Let's talk about another patient that went from dry to wet macular degeneration. In this patient's left eye, we can see this is dry mac to gen. And dry mac to gen usually looks like hyper and hypoautofluorescent little spots. These typically are associated with the drusen and with the retinal pigment epithelial changes. This patient was dry in the right eye as well for a while, but then went from dry to wet macular degeneration. So here's what it looks like. About 2 months after the patient developed symptoms. He came in late. He was on vacation, didn't want to break his vacation, interrupt his vacation. So he showed up and he really had a fibroglial scar. It's still somewhat active, as you can see. The dark zones meaning dead retinal pigment epithelium. This horizontal line going across is actually interesting. It's telling us that there's a rip in the retinal pigment epithelium. Sometimes in wet mac to gen, the RPE sort of rips and it wraps around itself, sort of rolls up like a rug, and that shows up as a hyperautofluorescent zone, as shown over here. Of course, we're going to do anti-VEGF in these patients. This one was treated within 24 hours in the affected eye, and he's actually been treated a couple of dozen times since over the last year and a half or so. Of interest, we can use OCT, but also ultra-wide field autofluorescence to show us change in these cases. For example, when we first saw this patient, over here on the left, we can compare the lesion to this vessel, and then about 3 to 4 weeks later, we can see that the vessel is here. The vessel didn't move, but the lesion actually expanded. So it's relatively simple to get a gestalt, look at these images, and tell us if something is actually changing or not. And that's very, very useful. It may tell us that the patient needs additional anti-VEGF injections. Okay, let's take another condition that's not common. Doesn't quite look like drusen, but it's very, very interesting, fundus albipunctatus, which is a form of congenital stationary night blindness. We can look above in this 9-year-old and see mostly reflections off the internal limiting membrane. That's all this is in the left eye. In the right eye, these are also reflections off the internal limiting membrane. We're not seeing very much with the color images. You can, if you expanded them, blew them up a bit. But with practically the same magnification, we're actually looking at the autofluorescent images, and we see these sort of remarkable dots. So fundus albipunctatus has a lot of these dots. They're sort of like very uniform. One dot looks like another dot. And usually these patients have difficulty seeing at night. By definition, it's a congenital stationary night blindness. So they're born with it. it's stationary. It doesn't really progress. It actually does progress slowly. And the fact that the patient has these hyper lesions as opposed to hypo lesions suggests that it actually will progress a bit. And we have seen that. However, usually the patients are unaware of any major problem. Their maculas usually stay okay, so the central acuity is okay. 2 points to be made here. One, or a few points actually. Again, symmetry between the right and left eye, which is actually very good, very high. This zone over here I might as well point out right below. And that's actually thought to be the closure of the fetal fissure. So of interest, for a while that was a mysterious type of line, but now we know that this sort of line or slight arc is really related to the fetal fissure closing. That's a published article within the last couple of years out of Columbia University here in New York. Of interest, in addition, is the fact that the reflections off the internal limiting membrane don't show up on autofluorescence. Autofluorescence tells us about the deep retina, the outer retina, the retinal pigment epithelium, and then the corresponding photoreceptors. Of course, it shows us the blood vessels as sort of in dark relief, but the internal retina, the sort of inner layers of the retina, which are closer to the vitreous, like the internal limiting membrane, does not show up on autofluorescence. But on a youngster, shows up very, very well on standard color imaging. But sometimes that gets in the way. For example, this here, is that a reflection off the internal limiting membrane, or is that actually a disorder at the level of the retinal pigment epithelium? Since it doesn't correspond to anything we have down here, in autofluorescence, this is actually just reflections off the internal membrane due to the patient's age. No treatment for this condition is available. Not really essential because, again, these patients actually do quite well. They do have some night vision difficulties. This specific patient has only very minor night difficulties. He says he only has problems sometimes going to the bathroom at night if he doesn't have a light on. But he does okay out in moonlight or with lights on and some overhead lights on a dark zone. If he's walking in the street and there are street lights, he actually sees fine, he says. Okay, let's go into another series of disorders. Let's talk about inflammatory or infectious diseases. This is Harada's disease, which could be the retinal component of something that we call void Kayanaga Harada. This is a published paper. We've seen a couple of these, but these were very good images, I thought. And we could compare the color images above in this patient with Harada's disease to the images below, which are autofluorescent, of course. Notice that, yes, there's some dark zones, which means dead retinal pigment epithelium, but some brighter zones as well, which means that this is hyper-autofluorescent, which means it's active, sick retinal pigment epithelial cells, and this pattern would suggest that this patient should be treated. Now, the treatment for Harada's disease is usually systemic steroids. So if you see this image, working with a retinal specialist, this would suggest that this is still active and this patient does require treatment, and it's usually going to be systemic steroids. Here's another case of Harada's disease, and notice in this instance a little bit of a difference. The vast majority, if not all of the lesions, are now dark, which means the retinal pigment epithelium is dead. The associated photoreceptors are dead. So this is the left eye. The patient will have very reduced visual acuity because of the macula involvement. But we're not seeing bright zones. We're not seeing zones as we were seeing over here. So we're saying that this patient could be followed without treatment, without systemic steroids at this point in time. So often, autofluorescence may be useful in infectious and inflammatory disorders to tell us whether a condition is active or inactive. For example, let's talk about congenital toxoplasmosis. This is a patient that came in with a history. He said, I was born with toxoplasmosis. I'm a low vision patient with 2400 acuity. You know all of that stuff. And he said the low vision specialist just wanted me to see somebody in retina that has a little bit more experience in retina to tell us whether anything has to be done. In any case, the acuity is gone because the macula is wiped out with this congenital lesion, but there are a lot of satellite lesions, which occur often in congenital toxo. Here's the autofluorescence of this, the ultra-wide field autofluorescent images. And all the way out here temporally we can see we have a dark zone, but it has a bright border around it, suggesting that this actually may be active. And that we get concerned about. Now, I then put on a 3-mirror lens on this patient and was able to see some vitritis, some cells right in front of the lesion. Not a lot, but some cells right in front of the lesion. So this is actually an active lesion. And that's important to know. Generally in toxoplasmosis, we talk about treating lesions if they threaten the disc or threaten the macula. Here the macula is already wiped out. This one's obviously not threatening the disc or the macula. So as long as this patient doesn't have a terrible vitritis, we can actually follow this patient without treatment, and these toxo lesions typically burn themselves out. So this is really reactivation of congenital lesions, and it can happen 2-3 decades afterwards. The organism Toxoplasma gondii can actually live encapsulated within the retinal nerve fiber layer for decades, which is sort of surprising. And then sometimes it gets triggered by stress or a problem with the immune system, like for example patients that have AIDS, that develop AIDS, actually do develop, if they had toxo earlier in life, the toxo lesions can become active. Here's his left eye. Again, he was a low vision patient. The maculas are wiped out. His acuity bilaterally is 2400. Satellite lesions here, as you can see, but nothing dramatic going on the autofluorescence. So it looks different than this one, where there's a large lesion surrounded by a hyper autofluorescent zone suggesting activity and something that has to be either treated or followed. In this instance, just followed. These tiny little spots here I would look at, but I wouldn't be very concerned about them. But they should probably be followed as well. Okay, another condition. Here's a patient with systemic lupus erythematosus, age 39, female, and she's been on treatment with Plaquenil, about 400 milligrams a day for the last 10 years or so. So she's at risk of developing Plaquenil toxicity. Here's the images of the disc and macula blown up, the Optos images blown up. We can see some reflections off the internal membrane. Over here, as you can see, sort of like a young-looking fundus, interestingly enough. But here's the autofluorescence. Clearly, there's what we call a bullseye, and bullseye lesions are highly suggestive of a patient who has Plaquenil toxicity. So you might not see it with standard color images. You may not see it with an ophthalmoscope. You probably will find abnormalities on OCT, and if you happen to be one of the few people out there that have various pattern ERGs, the pattern ERG or more likely even the multifocal, the MF multifocal ERG will be abnormal. So in any instance, a lot of these toxicities, Plaquenil toxicity, even Accutane, the acne medicine has at least 2 cases that have been published, have similar types of bullseye lesions. Bullseye lesions, by the way, don't automatically mean that the patient has Plaquenil. Let's say this patient is not on any drug, and therefore we don't think it's Plaquenil or any other drug-related toxicity. The same bullseye can be found in early Stargardt's disease. It can be found in cone rod dystrophies as well, and those are 2 in the differential diagnosis that we must consider. An interesting disease that we're going to talk about now, a disorder that is called Azor, named in 1993 by Don Gass out of Bascom Palmer Institute in Florida. And actually, the first patient he ever saw with this condition, he didn't know what it was. It was an optometrist's wife. And he said, I don't really know what this is, but come back in a year and I will definitely figure it out. Patient comes back a year later. Then he tells the patient that she is one of 13 that have this new entity that he figured out, and it's called Azor. Again, this is back in 1993. The first A stands for acute. The Z stands for zones, zonal. Certain zones of the retina are affected and other zones are not. The first O stands for cult, which means it's typically invisible to ophthalmoscopy, at least in the early stages. And then the OR stands for outer retina. So it's an acute zonal occult disorder of the outer retina. Of interest, here's one of the, I have maybe a half a dozen patients I've been following with Azor over the last several years. And here's a patient who's about, I guess, 70-ish or so, and she has a history of Azor. Her I've been seeing for 10 years. She has Azor in her right eye. Now that we knew. It was a relatively simple diagnosis to make at the time with the appropriate technology. But here is her left eye, and she never had any symptoms out of the left eye. The right eye, she was complaining about photopsias and other things, including a blind spot. Now she's having symptoms 10 years later in her left eye. And here's what she looks like. So the disc looks okay, except some little tiny spots around it, hot spots, which are hyper autofluorescent, suggesting maybe there's something brewing here around the disc. This lesion here wasn't present 6 months earlier, the one above the disc. So this is actually a new lesion, and it's hyper autofluorescent, which means she's already lost retinal pigment epithelium and corresponding photoreceptors, and hence would have a scotoma below fixation when you do visual fields on her. It does have some spots around it, suggesting that it could be active. it's suggesting that it is active and is not going to really spread rapidly. So the point is, we had the diagnosis. We had OCTs in addition to the autofluorescence, and we told the patient, let's take a look at you in about 6-8 weeks. Here she is about 6 or 7 weeks afterwards, and clearly it changed. We'll show you the comparison in just a moment. Now the disc is clearly involved. The lesion that started above the macula has now expanded to the disc, if you will. She does have photopsias, and she is complaining about a blind spot below her fixation. So here we're looking at her over a period of about 6 to 7 weeks. And we can see a dramatic change in this relatively short period of time. The major lesion above the fovea is actually larger, as you can see. It's closer to the fovea now, 6 weeks afterwards. We're very concerned about fovea involvement. That would wipe out visual acuity, of course. Notice that here it seemed like it was separate and distinct from the disc, but over here 6-7 weeks later, it actually is combined with the disc, so we have one lesion. And notice that it's still surrounded by this hyperzone, which strongly suggests that this is still active, so this may actually progress. The good news, if anything, is right over here closest to the fovea, there's not much going on. This doesn't really have a hyper autofluorescent band here, which is close to the fovea. So she has now been followed for about 8 months like this, and the good news is she's going into a stage where we don't think it's changing anymore. So it's becoming much less active at this point in time and didn't require treatment. Treatment would be complicated, but this is actually thought to be probably an autoimmune disease, a drug called Imuran, which actually has been shown to work in select cases. A few cases have been published. I have one patient who we treated with Imuran who actually was successful, was able to slow down and actually stop the condition. So that's an interesting one. Now, Azor, you might say, oh, I'll never see Azor. You might not, because early on it's invisible to ophthalmoscopy. Then it might be simple to see, but the autofluorescent images are very, very useful. Larry Anuzzi, who's a friend of mine, put together a paper, some of my cases, but cases from a few different facilities, and he actually looked at 300 Azor patients and reported, I guess within the last 12 months, on 300 Azor patients. So it's not that rare. It's probably missed a lot because, again, it's, occult, which means hidden, occult. You don't see it. It's invisible to ophthalmoscopy in early stages. Eventually, there are pigment epithelial changes that you will see with an ophthalmoscope. But in early stages, Azor is truly, in my opinion, I've seen a few of these, that are completely invisible. We've published a few, and later on, they may become much more obvious. But it truly is not that rare of a disease. If someone could put together a series of 300 or so, it must be much more common than we ever thought. And there's that comparison again. Okay, let's talk about retinitis pigmentosa. A few cases of RP. I'll start with an atypical RP. Usually in school, we teach RP as being a retinal degeneration. It starts in the mid-periphery. There may be a visual field loss corresponding to that, sort of a ring scotoma. Here's a patient that, when I first saw the patient, I did not know this patient had a form of retinitis pigmentosa. The patient was referred to me. She was 45 years of age. She was a 5-diopter myope. She was complaining about difficulty seeing at night. The doctor gave her special reading glasses or special night glasses with a little bit of extra minus, like a -5 or so. She said the extra minus, stronger glasses for driving helped, but she still felt she had a problem. So that's when she was referred to me. Anyway, looking at her, she has a normal-looking disc, pretty much, normal-looking macula. Choroidal vessels look okay. Out here in the periphery, she has a paving stone degeneration. Paving stone is very, very common in myopes. I would say the statistics actually are, if you're about 50 years of age and you're about a 5-diopter myope, you have about a 50% chance of having paving stone. Easy numbers to remember. So here's what she looks like in her right eye, and here's the left eye. Looks very symmetric. Looks like paving stone in the peripheral temporal retina. Disc looks okay. Macula looks okay. Not really much going on. So we can sort of say, okay, don't really know what's happening here. Well, since these are autofluorescent images with a Daytona, we can spend an extra minute or so and let's push the autofluorescent button and get another set of images. Here's her right eye, and here's her left eye. So of interest, the macula really looked okay. There wasn't really anything going on here that was obvious. In the left eye, there wasn't much going on. Acuities were 20/20. If I forgot to mention it, acuities were correctable to 20/20, actually to 20/15. If you push her a little bit. So good central acuities. But notice that she has these two lesions below the macula in both eyes. Now these are hyper-autofluorescent, suggesting that this is a metabolically active zone of retinal pigment epithelium. It's sick. It hasn't died yet. There's nothing. There's no hypo there. So we don't have deaths. This is probably a relatively recent phenomenon, interestingly enough. In the periphery, in the far periphery, we have what could be paving stone. However, this is now sort of bordered with a zone of hyperautofluorescence, suggesting that this is really not paving stone. It's probably a peripheral retinal degeneration. It's really part of this retinitis pigmentosa. Again, RP more often than not starts in the mid-periphery, but there are a lot of atypical cases. We can get far peripheral abnormalities and lesions in the macula. We actually saw an optometrist that had something similar to this, and we published him. Again, central lesions and far peripheral lesions, nothing going on in the mid-periphery. That was published, I believe, in Primary Care Optometry News about 4 years ago with autofluorescence images. So this one's interesting because it is retinitis pigmentosa. We went ahead and got an electroretinogram, a flash ERG. It was down by about 50%, which is fairly typical. We don't have this, treatment for this disorder at the present time, but we consider putting these patients on vitamin A palmitate, 15 to 18,000 international units, fish oil, omega-3s, and also lutein zeaxanthin and mesozeaxanthin are also recommended. There's some studies suggesting that sort of profile actually does work. Another case of retinitis pigmentosa, and I personally have seen probably 100 of these over the last 4 or 5 years. This one was just published in September 2015 out of Australia. And if we look at the standard image showed here, you can see most of this is in the mid-periphery, which is fairly typical. As we can see, this pigmentary change, hence the name retinitis pigmentosa. But you can have RP without any pigment whatsoever. The more interesting factor of this one is this bullseye. This we're not seeing with the color imaging. We're not seeing it with a standard ophthalmoscope, but over here we can certainly see a bullseye maculopathy. So bullseye maculopathy is very common in retinitis pigmentosa or in cone dystrophy or inverse RP, and as I mentioned before, in Stargardt's disease as well. That's all in addition to the toxicities such as plaquenil and Accutane. So here, additional information is being gained. The smaller the circle, the more problem the patient has. This is active. This will typically increase or sort of increase towards the fovea. So in a few years, this may actually wipe out the fovea. This patient would be much better off if the lesion was this big. So we have patients with retinal degenerations that sometimes have large rings. This patient doesn't have a large ring, may develop one perhaps, but the smaller ring suggests that the macula is actually sort of threatened by this lesion. Here's the right eye, here's the left eye with the fluoro. And notice in this one, at least at this magnification, we sort of get that sense of this, the small ring, which is problematic the smaller it gets closer to the fovea, and this mid-peripheral ring over here, as we can see. Pathological myopia. This is the highest myopia I've seen in the last 5 years, about minus 34. Here's what the patient looks like clinically. Acuity is actually not bad, 2400. This is a little bit of retina right in the center that's still intact. This patient has a bunch of rings also. These are actually posterior staphylomas, and there are several of those. In addition to retinitis pigmentosa, that obviously shows pigmentary changes in the mid and far periphery, very high myopes also develop very similar pigmentary changes in the periphery, but usually it's not really bone corpuscle. But this is fairly typical of a very, very high myope. This white zone that you're looking at is primarily sclera, so most of the retina and most of the choroid is actually missing. Here's what it looks like on autofluorescence. So of interest, we are getting some rings, and we're getting some pigment. So this is not retinitis pigmentosa. This is just a pathological myopia that can mimic it to some extent because of the pigmentary changes in the periphery. However, typically not bone corpuscle, or not as many, not the highest percentage. And these rings over here are actually correspond to staphylomas, where in the retinitis pigmentosa case, they're not truly related to stretching of the eye. And you wouldn't see them on, say, B-scan or even with depth with binocular indirect ophthalmoscopy. So the composite shown here and the autofluorescence shown there. Okay, again, some additional information suggesting that this zone over here may actually mean that this is still stretching. This could be some activity. This patient is a 34 diopter myope. Perhaps they're going to actually turn out to be closer to a 40 diopter myope. Axial length, if I remember, was 35 millimeters. Okay, we're about out of time. Let's conclude a few things. We'll say that fundus autofluorescence should be included in all comprehensive eye exams. As long as you have, say, a Daytona and you're taking color images, you might as well go ahead and do the autofluorescent images as well. Because you never know, you might see things that are going to completely surprise you. Autofluorescence assists in the diagnosis and management of a whole series of retinal diseases. And as I've tried to demonstrate, there's a surprising number of disorders that are invisible to ophthalmoscopy and to standard color photography, even ultra-wide field color photography, but remarkably easy to detect with autofluorescence. And the autofluorescence can differentiate active from inactive lesions, and that may allow for more timely intervention if there is treatment available. And I thank you very much for this very late hour. I sort of apologize for that. We're approaching 9 o'clock, and I assume we're going to be taking some questions. I don't know exactly in what format, but I think we'll do that.
Great. Thank you so much, Jerry. That was very informative, and I hope everyone on the call really got as much out of it as I did. For those of you who don't know me, my name is Sharon Shepard. I actually work for a company named Opt. We sponsored this webinar, and thank you to Jerry for his time. And we have several questions that we would like to ask, and Jerry can answer those. So, Jerry, you touched upon the fact that there's different ways to image with fundus autofluorescence, one being blue laser, one being green laser. Can you tell us a little bit about the differences between those and which one is better than the other, in your opinion?
Well, the original autofluorescence was actually done with the Heidelberg Spectralis system, and that was using a blue laser at 488. A lot of the other systems that are out there, like the Optos Image of Daytona, is actually using something closer to 532. So that's more in the green. It turns out that the blue is actually more dangerous. Optos made a decision on autofluorescence to only take one image. I was actually involved when that decision was made. We were looking at averaging, 3 or 5 or even 10 images to see whether we got any additional information. The Heidelberg people do average. They may take 5 or 10 or 15 or 20 images and sort of average them together to get the images. Now, the problem is that that's a brighter light, and the 488 is certainly more dangerous, and the blue is more dangerous than the green. So that's one factor, especially in patients that have things like Stargardt disease or retinitis pigmentosa. We're concerned about introducing too much light. The second factor is that lutein zeaxanthin and mesozeaxanthin, which are the 3 carotenoids found in the macula, form the macula lutea, or the yellow macula. The more yellow pigment, which is a good thing, have high levels of these carotenoids, the more yellow pigment you have, the more blue light is going to be absorbed by the lutein, these lutein, zeaxanthin, and mesozeaxanthin, those 3 pigments. Now what that does, if somebody happens to have a very high level of lutein, zeaxanthin, and mesozeaxanthin, you may get what looks like a hypo autofluorescent macula, which means it sort of could shield could sort of suggest that there's a maculopathy when there's not a maculopathy, or sort of another related factor is it may prevent you from seeing a maculopathy that's actually there. So although the 488 is very good for certain things, I prefer being in the 530 range because the green is safer, and because the macula is the 530 ones are not really affected by the macular pigment, by the lutein, zeaxanthin, and mesozeaxanthin.
Would fundus autofluorescence show the NFL distress caused by glaucoma that would be found using a visual field machine? For example, would you be able to see a nasal step?
Okay, the answer to that is no. I made the point before. No, let's do it again. If I didn't cover it in enough detail, autofluorescence tells us about the outer retina. It tells us specifically about lipofuscin within the retinal pigment epithelium. Okay, it will tell us about the photoreceptors indirectly. It tells us nothing about the inner retina. The inner retina would be the internal membrane, the ganglion cells, and the retinal nerve fiber layer. So I've looked at patients with glaucoma with obvious retinal nerve fiber layer defects they can see on ultra-wide images. Matter of fact, we have something called Retina Revealed, a free website, www.retinarevealed.com. We have some beautiful ultra-wide field images of glaucoma in there, and lots of other things, of course, also. And that shows up really nicely if you go to green laser separation to pick up the retinal nerve fiber layer. But autofluorescence gives us no information about the ganglion cells or the nerve fiber layer or the inner the internal limiting membrane. So in reality, it may help you indirectly, because if somebody has a visual, visual field loss, like if you think in terms of that patient with atypical RP, that would have given you a field loss that gives you sort of an arcuate scotoma. So you might say, gee, does this patient have glaucoma? But then again, you do the autofluorescence, and you can see that the patient had that lesion that was in sort of like the position and contour that would give us an arcuate field defect, and that we know would be due to this retinal degeneration and not due to glaucoma. So directly, it gives us no information about glaucoma. It doesn't tell us about the ganglion cells, doesn't tell us about the retinal nerve fiber layer, but it may be very useful indirectly by telling us why a patient has an arcuate scotoma or nasal step.
For bullseye on autofluorescence, is vision usually affected or unaffected?
Okay, if you have early plaquenil toxicity, you'll have the bullseye lesion before the visual acuity is affected. So most of these patients will start with 20/20. If it's not detected early enough, and if the plaquenil is not stopped, not discontinued, the patients will eventually develop involvement of the acuity. Again, in the free website, www.retinareveal.com, we actually have, I think it's case number 2, we show you what's actually happening with at least OCTs in that instance. We have some beautiful OCTs in that case of what's actually happening in plaquenil toxicity. And it shows that in one eye there's still 20/20 acuity, the so-called photoreceptor integrity line is intact, but in the other eye it's not. And autofluorescence will tell you, if you just have a ring, sort of a bullseye, and the central part of the bullseye looks okay, then the patient's probably going to have a normal visual acuity. The concept is we want to be able to pick up plaquenil as early as possible, because plaquenil toxicity can continue on even if you stop the drug. There's some cases in the world's literature where the drug was discontinued and the patient continued to lose vision and central fields for up to 5 years. So early detection is best. The world's experts are now saying the 3 technologies that you should consider using. One is autofluorescence, the second is OCT, and the third is the one that I mentioned before that most people don't have. Either the multifocal ERG or perhaps the pattern ERG would work as well. Yes, plaquenil is something that may not affect the vision early on. It's not supposed to early on. You just have to make an early detection and to try to prevent progression.
Will toxicity be visible on AF before 10/2?
Before 10-2, okay.
Yes.
Well, Michael Marmer, the world's expert on toxicities, on plaquenil toxicity, his name's on most of the major papers that have been published. And he says that the more tests you do, the more likely you'll pick up an early plaquenil toxicity. So he's saying on some cases the autofluorescence may be the earliest abnormality. In some other cases it might be OCT that's the earliest abnormality. And in some cases it might be the electrophysiological profile, the multifocal ERG, and even in some cases it may be a 10-2. So he's suggesting doing as many of those 4 procedures as you can. Certainly that's including visual acuity and looking at the fundus directly. But those 4 procedures, the 3 new ones that we talked about, and the one that's been around for a while, the 10-2, is certainly useful. By the way, it's 10-2 to white, not to red. Red seems to complicate the interpretation of the results. So occasionally, very rarely, a 10-2 may give you information before the other 3, but usually my experience is that the autofluorescence is actually probably the best, the easiest to make an early detection, because those bullseyes are really easy to pick up with the Daytona system.
Other than optic nerve head drusen, what would cause AF in the optic nerve head?
Could be, well, certainly we think that optic nerve head drusen, and I didn't show you any of those. So, again, if this was a 3-hour course and we're doing 50 cases, I would have shown you 1 or 2 cases of optic disc drusen, which are actually fairly dramatic. And sometimes the autofluorescence is a really good way, and sometimes the best way of picking it up. B-scan is also useful, and OCT can do it on some occasions. But in addition to just disc drusen, you can get astrocytic hamartomas that may do that. And those are the only 2. I guess some other kinds of tumors of the optic nerve can also do it. Glioma, theoretically, an optic nerve glioma can probably hyper-autofluoresce. But I have seen recently an astrocytic hamartoma, interestingly enough, in a retinitis pigmentosa, or actually in a patient with Leber's congenital amaurosis, and that's in the world's literature, and that actually glowed pretty much. So certain hamartoma is astrocytic, made up of astrocytes, that will actually show hyperautofluorescence as well. But probably some other tumors or conditions that are very, very closely associated with the disc, sometimes central serous, right around the disc it will glow, but the disc glow itself is usually dysdrusen. Now, dysdrusen are not rare. Dysdrusen occur in about 1% of the population. On histopathology, there's one study suggesting that dysdrusen are as common as 4% of the population, or 1 in 25. So I've seen a bunch of patients who it wasn't at all obvious they had dysdrusen with stain examination, and yet when you did all fluorescence, sure enough, they just really show out really well. Treatment for these dysdrusen, we don't really think there's any effective treatment at the present time, but they can unfortunately progress throughout life, and they can be associated with nerve fiber layer loss and with visual field loss as well.
In the final case that you just showed, why did that disc appear light in color?
Okay, well, this is the high myop, and that's actually a good question. The disc is over here. Okay, and it's slightly light, but nothing looks very, very dark. Even the vessels don't really look that dark here, but the disc does look slightly light. I don't know. It's probably stretched all the way backwards, but I can't say for certain. But you're right. This is sort of uniformly slightly bright. Again, the contrast of the image isn't that good. This patient actually did have cataracts in addition to this 34 diopters of myopia. But this is not a typical pattern of disc. Most of these discs actually somewhat darker, as we showed you previously. The vessels usually look a little bit more, a little bit darker. But recall, this is a very pathological eye with an axial length of 35 millimeters with a ton of stretching in this 34 diopter myop.
Does Azor have a predilection for central versus mid-peripheral retina? And are there any typical levels of acuity loss?
Often in Azor, the acuity is actually fairly good. And here's an Azor with acuity. In this case, the acuity is actually 20/20. Usually, the lesions are close to the disc. Often, they're contiguous to the disc, as this one is. We do have a paper with Larry Yanuzzi it's been submitted for publication, where we have several cases where the lesions are actually, they're far peripheral lesions as well. Matter of fact, this patient, I don't have the image here to show you immediately, but this patient in the right eye has far peripheral lesions, these giant concentric lesions all the way in the periphery. That second eye also started in the center, but now that she's had Azor for many, many years, for several decades, the patient does have a peripheral lesion. But Azor usually is closer to the disc. It's usually more of a central lesion. It can affect acuity. It can actually cause, we have one case of Azor where there was a bitemporal hemianopsia, amazingly, and the bitemporal hemianopsia had lots of doctors thinking that, gee, this has to be a pituitary tumor. 3 MRIs were negative, and then when we finally worked the patient up and followed the patient, it turned out it was Azor. Azor that actually did, in a sense, respect the vertical meridian through the fovea. Surprisingly. And that case is published in a CD-ROM that we did on visual fields, pathways to visual field interpretation. And I have access to that if anyone's interested. But again, generally, it's going to be more central than peripheral. The fovea may be spared, as in this case, but some of these cases will eventually lead to abnormalities in the far periphery. But I think of the series that we looked at, the 300, I think there are only 3 or 4 that really had dramatic abnormalities in the far peripheral retina. So that would be 1 out of 100 or so.
As far as Plaquenil goes, at what frequency should the test be done in autofluorescence?
Well, some people would suggest doing it, early on within the first year or so, and then if there's nothing, maybe skip to year 5, and then probably on a yearly basis. The statistics suggest, and the statistics have changed a little bit. It's a little bit more common than we had thought previously. But if you're a Plaquenil patient for 10 years on about 400 milligrams, you have a 1% chance of having a serious retinopathy, having toxicity. Some of the newest studies is one out of California that Michael Marmer was involved with. And my interpretation of that study was it's actually more common than we thought previously.
Great.
So again, early on, probably get a baseline, then you can probably skip several years. But certainly from year 10 on, you probably want to do it at least once a year, possibly even twice a year. And maybe from year 5 to year 10, maybe once a year, once every 2 years. Again, it's related to the cumulative dosage, that's one factor, and the number of years you've been on.
On that last case, you mentioned just now that there were cataracts involved as well. And how much do cataracts actually impact the quality of the FAF imaging?
The general rule is that Optos, Daytona, the one that we're using in this instance, or all Optos images, are using laser, and laser penetrates better than white light. So we actually get better penetration, better images. If you have a 4+ cataract, we're not going to be able to go through it. But a cataract that may hamper you from seeing the fundus with even a binocular indirect, you may be able to get a relatively good Optos image on it. So generally, it does better than standard photography and does better than standard ophthalmoscopy because it's using laser, and the laser does seem to penetrate better.
So with regard to fundus autofluorescence in general, do all white active thick areas become black over time as the area is dead?
That's a good question. I wish we actually had an answer for that. We think probably yes. We think that most of the bright lesions will eventually become dark. Sometimes it's relatively rapid. In dry macular degeneration and something called geographic atrophy of the retinal pigment epithelium, you can see changes over a period of just a couple of months, where the light zone, you sort of have a big black center, and then you have a peripheral band around it, which is bright hyperautofluorescence. If you look at those patients every 3 months, and I've done this in several cases, you can actually see that the bright zone is then replaced by a dark zone, and the bright zone just continues to go further out, meaning that the lesion itself is getting bigger. In some cases like fundus albipunctatus, which we mentioned, we showed you one case of that, I haven't seen any cases of fundus albi where the spots actually have become black. So it's interesting. They're bright because there's some type of abnormality, a sort of sick RPE, but in that specific condition, it seems like it stays sick chronically and doesn't seem to progress very rapidly, just minimal progression. But most often, the light zones become dark, and sometimes it's frequent. Sometimes it can be relatively rapid within several months. In that Azor case, I think we're able to see that. Yeah, right over here. So we can see here, this is early on. So these are lighter zones over here, and that is sort of, at least over here, it's sort of filling in. You can see it's going across. So this one is a fairly good example of what's happening. Of interest, when I took the image on this day, we saw a bunch of spots around it that were hyperautofluorescent, but remarkably, in just a period of like 6.5, 7 weeks, this extended all the way across and came very much closer to the fovea. So here's an area where some of these zones, some of these have become black, and some of the white ones have actually filled in. You're getting more of a white zone around it. But if you just do the comparison inferiorly, you can see it clearly grew, it clearly got closer to the fovea. This distance is certainly much larger than this distance. So it's much closer to the fovea 6.5 weeks later.
We have a couple of questions here about doing AF with kids. Like when do you suggest starting doing autofluorescence, and is it do you think that they should be dilated first, or is it fine to do it without dilation?
Well, if you get a good image without dilating, I'm pretty happy with that. You know, certainly something we came up with years back, and that is best is both. It's always best to do ultra-wide field imaging along with dilation. But there are many cases where the autofluorescent imaging and the standard color imaging is giving you so much information without dilation that dilation probably is really not necessary. So it's like, do you want to put somebody through it? And a lot of patients, if they're given the choice, you would prefer having the autofluorescent images. Of course, you may have noticed that a lot of these images, we're not seeing a lot of lashes, so we sort of take care to try to get the lids out of the way to try to get images where we're really getting, 200 degrees across. If a patient has symptoms of flashes and floaters, I think those patients should all be dilated. But a typical routine patient, without flashes and floaters, without anything new, I think autofluorescence is certainly useful. My experience in the States, and I've been involved with about 400 medical malpractice cases, and I have a book coming out on the do's and don'ts of rendering ophthalmic care, which relates to malpractice cases. We picked out 100 cases which are sort of exemplary and educational. In that instance, I've never heard of a case where an optometrist has gotten sued because he didn't dilate and did do, ultra-wide field imaging instead. So that, to my knowledge, has not occurred yet. It seems like you're getting a lot of information from these images, but again, if the patient has symptoms at all, flashes, floaters, those kinds of things, then I think it certainly makes sense to go ahead and dilate as well. Let me tell you about one of the cases out of those 100 that we're publishing in this book is a patient who was in her first trimester, and she was a myope, and she was 29 years of age, and her doctor was a female doctor, age 29 years of age. She was pregnant for the second time. The first one was a miscarriage. Her doctor was also trying to get pregnant, and she was complaining of some vague flashes. At age 29, she was in the first trimester, and her doctor said, you know what, we could dilate you, putting drops in your eyes. And both the doctor and patient thought, well, let's not do it. This doctor didn't have an Optos, and this doctor didn't have a B-scan. So she just said, well, if they get worse, come see me sooner, or if not, I'll see you right after you give birth. So she shows up about 8 months later or so with a little tiny adorable little boy, and she gets dilated, and sure enough, she has a mid-peripheral malignant melanoma. And then the eye was enucleated, and it turns out that her liver enzymes are going in the wrong direction, suggesting that she actually has metastatic melanoma to her liver. And statistically, she's going to be dead in a year or so. So that's a horrendous case. Of interest, the female optometrist who was also trying to get pregnant, as I understand the case, felt that she wouldn't want herself to have drops in her eyes because of the risks in the first trimester, even though the risks are really, really minimal, and you can argue there are no risks at all. But if she happened to have a spontaneous abortion a week later after you dilated her, if you had a lawsuit, that wouldn't be so surprising. Now, I think Canadians are less concerned about lawsuits than Americans. But in any instance, that optometrist could have done a very, very good job by doing an ultra-wide field image if it was available, or if it's not available, send it to a colleague of yours down the street or across town that has it, or do a B-scan ultrasound. Ultrasound is another safe procedure. Any OBGYN will testify that ultrasound is safe. They do it all the time, right through the, right on the surface of the abdominal cavity, and sometimes intravaginally. So ultrasound is thought to be safe. Of course, a probe close to the eye, an ultrasound probe close to the eye would be safe as well. So in that instance, the better test, ultrasound's great, but it's not going to pick up a tiny little, horseshoe tear. But the ultra-wide field imaging devices are very useful in those cases where you really don't feel comfortable to dilate, or the patient doesn't want to be dilated.
All right, Dr. Sherman, thank you so much for taking the time this evening to lecture to us all up here in Ontario. Greatly appreciated. I think the versatile technology that Optos is presenting here, it'd be interesting to see that poll that we used earlier before from 25% only using it now, and to see how high that would actually jump up in about 6 to 12 months. I do want to thank all the attendees as well, Optos for sponsoring this, as well as the OAO for the rest of the members for putting this together.
Well, thank you for the opportunity of presenting some of my favorite cases to you. Again, I would have preferred 50 over 15, but I guess it's not a bad start. Thanks. No. Thank you, everyone. Everybody have a good evening.